Thank you very much, and thank you for inviting me to speak today. I think you'll see that some of the themes in my talk are going to be similar to what you just heard. I do occasional proctoring for Intuitive. I can't really count well, so I'm going to move on. And my goal for today is to discuss understanding the approaches and priorities in treating perforated colon and rectal cancer, understand the differences between when perforation happens proximally versus distally, and then discuss some of the specifics of rectal cancer perforations. So, globally, colorectal cancer presents with obstruction or perforation about 50% of the time, obstruction more than perforation, but it's actually quite common. And the perioperative mortality is significantly increased compared to your regular scheduled colectomy. Now, the presentation really varies depending on where the perforation actually is. More often than not, when there's a perforation at the site of a tumor, the symptoms are going to be mild. People will show up in the emergency room just kind of generally not feeling well, maybe a little bit of a fever, but not necessarily all that impressive sometimes, at least at the first glance. And then an in-hospital mortality for these folks has increased by about 37%. Now, this is very different when people have a distal obstruction with a proximal perforation. Those folks will come in septic with spillage, peritonitis, and everything that goes along with that, including increase in mortality by up to 60%. CT scan is going to be your study of choice. If you look at the graph down below, the ultrasound is really going to miss a lot of different things. X-ray is going to lack the details. The enema actually can compare to the CT scan, but I'll submit to you it's probably going to be really challenging to get that study done in the emergency room in the middle of the night. And the CT scan can provide a lot of additional information that is going to potentially change how you're going to approach this patient, such as, are there metastases? Is there something else going on? Is there, what's the anatomy like? And flexible sigmoidoscopy or flexible endoscopy is really not needed. It's nice to have in the operating room, but you don't really need it for diagnosis. So, when we talk about this cancer that's already not just obstructed, but perforated, your priorities change. And the first priority is really a damage control. Okay. The second one, close second, but still second, is your oncologic outcomes. And then after that comes what are we going to do in the future. So once you get this patient to an operating room, oncologic resection is still preferable if it is at all possible. And that means removing the primary tumor, high ligation of a mesentery with adequate lymphadenectomy, and then with or without anastomosis, and we'll come back to that. And there are a couple of studies looking at that. The lymph node harvest actually seemed to be lower in the cases of perforated cancer, although the number of positive lymph nodes was similar, but generally it is recommended that if you can do this, you should do that. Now, let's talk a little bit about the distal versus proximal perforation, what your options are going to be. So for a colon cancer that's perforated distally, resection with a Hartmann's closure is always going to be an option. It's a safe procedure, get them in and out, but as we all know, what's going to happen afterwards and getting them back to an operating room and the chances of taking down that stoma are going to be lower. You can do anastomosis with proximal diversion, and this is where you have to ask that same question that Dr. Curran asked, like how full is actually the colon? Because even if a colon is full and you anastomose, and even if you proximally divert it, nothing is going to stop that colon from decompressing liters of stool into the belly, making that patient sick again. And I totally agree, nobody is really a fan of Poopageddon, but at the same time, I think it does have a role in some of these patients, especially if I really don't want to be going back into that abdomen ever again. I use actually very same setup that Dr. Curran uses, and you have to, yes, you do have to make friends first, and then you do that procedure. And then the primary anastomosis occasionally is also going to be appropriate. For a proximal cancer, it is going to be a little different. Primary anastomosis is oftentimes quite feasible, especially if you can move your anastomosis away from an area that's all inflamed. Primary anastomosis with diversion or endoleostomy with mucus fistula. And I'll come back to clips in a little bit. Now, I'm going backwards here. Sorry. Here we go. All right. So it is going to be very different if this is a distal colon cancer with a proximal perforation and you're already dealing with peritonitis and everything else. Your options at this point include you can do a subtotal colectomy with endoleostomy because more often than not, the rest of that colon is not very healthy looking. Sometimes you can anastomose and divert, and then what I want to know is, well, how proximal that stoma is going to be. Because sometimes you can kind of do that, but then you're going to be pulling that small bowel to the left lower quadrant with a very thickened mesentery. It's not going to reach my stoma in that case is going to be somewhere in kind of closer to jejunum, and I'm going to be struggling with dehydration and other things for a very long time. And then resect stoma, mucus fistula, essentially, again, this is go back to that priority. You have to get that patient off the table safely. And this is where knowing, do I have metastasis? Is there something else going on is going to be important. What is going to be a priority once you get that patient out of operating room? And there is actually some data looking at that. And this is a study from 2019 looking at looking at the outcomes of perforation of a proximal versus distal. And what's interesting here is that the long-term outcomes were actually similar in most of the studies. It was during the initial part that people didn't do as well. So essentially, if you can get them through this initial period where some of these people with peritonitis obviously do worse, then they actually longer term will do okay. Now, what we worry about, obviously it kind of makes sense, is, well, now we have a perforated cancer. What does it mean for carcinomatosis? There's actually surprisingly not that much data on that. There are a couple of studies, there are a couple of attempts at systematic reviews and meta-analyses, and the data is all over the place. It's anywhere between 14 and 54%. But most of the studies that look at that are retrospective, and so it does seem to be increased risk, but it's actually not as, at least I would have expected it to be. Now, switching gears a little bit, looking at the rectal cancer. So almost by definition, that is going to be a locally advanced disease. That means the patient would benefit from chemotherapy and radiation. That means, before resection, that means that we actually have to change the plan. So in that situation, I would go straight to diversion. And as Dr. Kern discussed, either loop or Prasad stoma, kind of a divided loop. And it's, if you have to do what you have to do. If you need to pull up a transverse colostomy, I think that's fine. But as I learned from Dr. Nagel, actually, I prefer to pull them up on the left side. So when I come back to take this patient to an operating room, with distal, essentially that stoma becomes part of my specimen, and then I have the rest of a clean, nice colon that I can use as a conduit to bring it down. Ileostomies are not appropriate. It's not going to do what you need it to do. And again, just think about the next step, think about the future. A couple of kind of tips and tricks that I have utilized. I do like leaving clips, especially in a case like that. You can see everything is kind of inflamed. You're not going to know whether you completely cleared things or not. So sometimes I will leave clips, and if they tell me it's like, oh, right there, an abdominal wall, there was a positive margin, I may consider asking radiation oncology folks to, zap it a little bit or just wait and, things come back, be something very specific and target that. In that situation, I would also, if there is an amentum, I'll pack it down there. So kind of, I don't know if it works, but kind of makes sense to me to kind of isolate things a little bit. I'll biopsy, and this is where flexible endoscopy in the operating room can be helpful to make sure that you biopsy everything that you need to. these folks will need antibiotics, and that's going to really depend on what your hospital protocol and current recommendations are. And then in some cases, you're going to get in there, you think it's kind of diverticulitis, you think it's Crohn's disease, but it just looks a little funny. So the kind of a safe bet is to treat it as if it is cancer, because you're not going to be beating yourself up for collecting 15 lymph nodes on diverticulitis. But you are going to be very worried if it comes back as cancer and you have 2 lymph nodes. Now, just to briefly summarize, how do these patients actually do? This is meta-analysis looking at 2,700 patients for perforated versus non-perforated cancers. As you would expect, the 30-day mortality is higher for perforated cancers, so post-op complications, and overall survival and disease-free survival is somewhat lower, but actually not as much as you would think, as long as you can get them through this initial period. This is a study looking at obstructions versus perforations, and also kind of not unexpectedly, the folks who have perforations do worse, both in overall as well as disease-free survival. And then the complications and recurrence, I'm not going to spend all that much time here. Again, the data is kind of is as expected. I mean, the folks, mortality is actually higher for patients with obstruction, but complications are higher with patients with perforation. So, in summary, again, remember your priority. The first one is you have to get the patient with perforation safely off. Oncology is next. And then finally, plan for a future. Thank you.